Welcome to our podcast number 3 on CGM, and I'm joined, as in the previous podcast, by Doctors Hirsch and Aleppo, and we're going to conclude by discussing really our practical pointers on using CGM in patients with type 2 diabetes. But I'm going to hijack the beginning of this to tell about my experience, and then I'll turn to Grazia and Irl for their comments. But I was able to get a grant from a donor who really wanted to give back to people with diabetes. And he believed that the best way he could do that was to give our under-resourced patients CGM. And so I work in a comprehensive health center, which is a clinic that's a primary care-based clinic where we have our own diabetes program within that clinic. And basically, I've offered CGM to anybody who wants it. And this is primarily with patients with type 2 diabetes, and they're on insulin, they're not on insulin. It's just all comers. And we've been doing this in a systematic way because we wanted to get outcomes, and we've done a lot of surveys and things. And we're just approaching the end of the first year, and we have well over 100 patients that we've been following. And my team, my study team, has worked in this institution for many, many years. So they're all native Spanish speakers, and they all can really relate to the patients. And I can't stress that enough, is that if you try to teach technology to people without the right language skills, without the right tools to educate them, it doesn't work. And I've had people get really frustrated when they've been put on devices where the devices only speak English and the training's only in English and they don't speak English. So we have really culturally appropriate training for our patients. And we also go out of our way to help patients. So if they need to come in, we put the sensors back on, we do training in person, we do training on Zoom, we do everything it takes to help the patients. And we also, by the way, make it really easy if their sensor falls off to get another one. So we make it easy. And then we monitor everybody on a remote monitoring system that we designed, and we do it both in Clarity for patients on Dexcom, and we do it in LibreView for patients who are on Libre. So my staff is every single day looking to see if patients have episodes of hypoglycemia or disruption of sensor use, because that's actually what we find the most, is that patients' sensors fall off in the real world, that they can't, for whatever reason, get them refilled. So we want to ensure continuous sensor use. And what we've seen, at least in our preliminary data analysis, is that patients get better, that our average A1C reduction is over 1%. And this is strongly significant. It's more than seen in the mobile study, because basically we're like mobile on steroids, although that's a bad analogy in diabetes. But we're basically giving this very intensive follow-up. I do not make medication changes, but I recommend the changes to primary care. And one of the big things that I've done, and I think this is important because it was actually partly what I wanted to do, which is to drive the use of GLP-1 receptor agonists and SGLT2 inhibitors, because our primary care doctors don't use those agents often enough. So I do think I've increased the cost in terms of encouraging the use of those agents, but we have them on our formulary. And I think helping providers feel more comfortable using those agents. So in my use of CGM in type 2s, it's not just the lifestyle component, it is that I am intensifying their therapy appropriately. And we're going to have all the data eventually available for publication, but we're only halfway through the study. But I'm finding it's so useful. And our patients have really been loving it. And I didn't realize how much it would matter to them. But as we're ending the first year and they can't get free devices, they're just begging us for them, but I can't get coverage because they're not on insulin. So it's been sort of sad, and I'm a little upset that I have to stop it. So I'm trying to figure out how I can get more funding. But the point is it's worked really well in this population. And again, I think one of the big ways that this has been helpful is to drive appropriate therapy intensification. And that's something that we haven't necessarily done when we've used CGM in type 2s. So, Grazia, I'll let you make your comments on your practical use of CGM in patients with type 2 diabetes.
So, well, not only that, I totally agree with you, but I think we are in an institution, we're trying to do something a bit more for providers. So we felt that, yes, the endos are able to understand. We train our fellows from the very first day. We also are training our internal medicine residents. So my colleague and I wrote a paper on how to interpret CGM in very simple 3 steps so that we can extend this out, because once we use CGM more widely, we can't see everybody. We have to have our primary care colleagues help us out see the patients, and they see the majority of patients with diabetes type 2 especially. And so by having them having a simple way to approach interpretation, we hope that they will make it more comfortable and therefore more writing CGM. Because today, patients go to their primary care and say, I want the thing on my arm. I want the thing on my phone. They already want the CGM before the provider can offer it to them. And so for us in our practice, I agree with Irl. We try to do professional. Somebody who comes to us, we have no idea where they're at. We don't know what to do. We start professional CGM. And then we proceed with the person if they can afford it, if the cover is so forth and so on. But also what I found to be so incredible is sometimes patients who are on CGM end up coming off of insulin. And so they might stay on one long acting, so I know they can stay covered, but they do so much better. Like you experience, we use more GLP and they see the aha moments and they start to change their own exercise routine or even their meals. And what I found to be so empowering is that they become competitive with themselves. And so they have this Clarity or LibraView, whatever they use, and they try to get extra percentage every month, every week. And so they write us. And so one thing that I found to be very helpful in our practice, that now the patient, when they have an issue before the visit, in the middle of whatever, 3 months, 4 months, they say, okay, Dr. Aleppo, I have a problem. These are my glucose and my CGM. I'm having some issues. Can you please help? And that makes a huge difference. This defeats totally the therapeutic inertia, because you make interventions in the moment well before the next visit, and it can do so much better for the patient. They get better, they feel more comfortable, less anxious, move on with their situation. I find that to be extremely helpful, whether it's remote monitoring or through Clarity, they send us messages to my chart. That to me is one of the most important things. There's a big difference with somebody on BGM that never talk to us and come back 6 months later with whatever, or people on CGM and say, I'm not doing well, I don't know what's going on with me, or I don't know, I have to take steroids, whatever that might be. That communication, I think, is key to make these patients better over time, instead of having this long silence between appointments. That I found to be very not only helpful with the patient, but also for us, because we know they feel comfortable enough to get in touch with us, and we can do things to help them out, or see the educator, whatever it might be they need, but the patient initiates it. And when we ever had before patients with type 2 initiate anything, is the opposite. Now they initiate because they care. So I think that's huge.
I think it is huge. I'm going to play slight devil's advocate, though, because do you feel like that takes more of your time, or do you find it something that reduces time in the end because you've gotten your patients to their targets?
So they don't overdo it. Our patients don't abuse of it. So I feel very fortunate that they understand that when they write us, we have to answer a lot of these calls or these messages. So they're not really bothering us with that. But we also actually code for these visits. So let's say that somebody asked me to review a CGM and it's been more than 30 days from the last visit. I can code 95251 as non-face-to-face interpretation. And that is actually, in a way, pays for my time, even though it's a small amount. But there is an understanding that this is a medical service I'm providing for my patient, and they don't complain. They're fine with that. So they actually understand that. And so far, I've had no patients abuse of it at all. Really, I guess I'm fortunate, but we also train the patient to understand how to use that information, how to communicate. Because in the end, if you don't train the patient, they don't know how to respond to you, how to work with you, I guess.
But those are very good points. The reason I ask is because I know people in the system where I work are worried that there's going to be too many calls to the nurses or the doctors. And I'm with you, is that A, you can bill for it. But second of all, I don't think it's too many, because in the beginning, they may have more questions, but then you get through that and then they become much more engaged in their own care. And I think it's worth every second of it. But I think there is a learning curve. And I think that the education that we provide our patients around this is so important and helps them feel like they know how to respond. So I love your answers, but again, does fit with how I would have answered the same question, because we do the same thing. We want data, we want engagement with our patients, we want to help them. So, all right. So, Irl, why don't you bring us home? Tell us how you think this clinical world should be, and what are some pros you have that you think might help providers?
I think providers need to think about CGM for every patient they see with diabetes. If it's a patient on insulin, it's the first thing that should come across their mind. Now, for many places, literally on the first day of the diagnosis of type 1 diabetes, the CGM is started. Finger sticks are still started, but CGM. Secondly, for the type 2 patient on insulin, if they're not on CGM, there's really no reason why not to talk about it, even if it's somebody who's using it intermittently. And the same is true for the patient with type 2 diabetes who is not on insulin therapy. I just don't see any reason why not to. Now, I want to end my comments, because I know we're about out of time, with a devil's advocate who asked me a question at a recent meeting, who's very familiar with all the tirzepatide data that was published, and amazing data looking at normalization of hemoglobin A1C levels. And the question came to me, and I'm going to ask both of you, if you are starting a patient not on insulin on tirzepatide, or you could even say high-dose semaglutide, pick your flavor, why do I need CGM, especially if statistically those A1Cs are going to end up below 6%? Why do I need CGM in that population?
Okay, I'll answer that. Because I still believe that the patient seeing their data is much more empowered, especially the improvement. So that's where I come from. Patients who were on GLP, who saw a huge amount of improvement, and they say, okay, I want to get better. So I want to go up on the dose. I know that I don't feel so good because I may be some nausea, but I feel that I have a couple of patients where I'm thinking of right now who have had such difficulty just being on a long-acting insulin, and maybe some metformin, and so I was through GLP, and then the glucose are coming down. But there is the only way they can see it, because they don't just see the fasting, they see the postprandial curve, which you don't see any other way but with CGM. So why not?
Well, I will also say that I believe that lifestyle always matters. And I don't care what shot you're giving at what dose, how often, lifestyle matters. And when I've looked at CGM tracing on people who have their A1C is at target, you still see postprandial variation. And you can show that if you happen to eat, I don't know, Frosted Flakes, milk, and juice for breakfast, you're going to go up postprandially. And I don't actually think that's good for you. I'm a believer in that we should sort of modulate the postprandial as well as the A1C, and you're not going to pick up some of that postprandial jiggle. And it helps people learn about their bodies, just like wearing a Fitbit or something. But I don't think, and as you brought up earlier, we need people to wear CGM all the time who are in that category. So that wearing it the 2 weeks before or 10 days before their clinic visit is really, really helpful. And I think it helps them know. But I don't ever ditch lifestyle. I mean, there's no free lunch here. And, the notion that people have to eat well, they need to exercise, all of these things, that all the studies shows that people who eat better and exercise more are going to do better in terms of overall health. So it doesn't take away the need to do the right thing for your health. And I think that continuous glucose monitoring helps you understand what is the right thing for your health. So, Irl, what do you have to say to that?
No, I love your answers, both of yours, but I think this is the new question a lot of physicians will be asking and should be asking when we look at these powerful new GLP-1 drugs that are out now and coming out in the future.
Well, I think we're lucky to have them. I think you and I both are the same vintage, so we know where we started when we started our training in medicine. And I think we had non-analog insulin and sulfonylurea agents, and that was about it. Can you imagine?
Animal insulin and animal insulin.
Animal.
Yeah.
We didn't even have human insulin.
That's true. We didn't even have human insulin. It was amazing. It's amazing we're still here. But I love how far we've come. And all of us on this call on this podcast have really enjoyed being able to share our opinions about this. And we hope that you're encouraged to use CGM more. But again, make sure you work with whoever your educators are, whoever the companies are, to figure out how to get the data downloaded into your clinic. It's easy once you figure it out. And then make sure that patients get education however you can provide it. And there's all sorts of tools to teach patients, but they need to be educated. And then if you work with them, I think it will help improve their outcomes and really help your patients live better with their diabetes. And as Zora pointed out, maybe even their pre-diabetes, because I certainly have patients who use CGM for their pre-diabetes as well. And again, it's about guiding their lifestyle. So thank you very much. That's the end of podcast number 3 on continuous glucose monitoring in people with type 2 diabetes. Thank you.
Thank you.
Thanks, Anne.